So just wanted to welcome everybody to our September public board meeting for Northamptonshire Healthcare NHS Foundation Trust, and particularly a warm welcome to any governors who are observing us today, and indeed members of the public. We always welcome that, and of course this board meeting is recorded for the purposes of leaving it online for people to watch afterwards if they've not had the opportunity to do so. So just a reminder to colleagues around the board table that this is being recorded and live streamed. I particularly wanted to welcome Natasha. Natasha Fox has joined us as a new Associate Non-Executive Director. Welcome, Natasha, to your first formal board meeting. I know you've been meeting with board colleagues and we've met informally together, but it is the first public meeting to welcome you out. So a warm welcome to you.
Thank you very much, Chrisney.
And then also just wanted to welcome Faisal. I know Faisal, I think you were here last board meeting as well, but I just wanted to welcome Faisal and remind colleagues that Faisal will be taking over from me in about a month. So he's obviously here as part of the transition and handover arrangements that we've been enacting, and so delighted to have you here, Faisal. So thank you for joining. And also Sachin, just wanted to welcome Sachin to Sachin is covering for Itai. Martin BK, our medical director. So welcome, Sachin. Good to have you here. And I think that's everybody. Just a couple of apologies to note. Robin Burgess, non-executive director. Itai, I've already mentioned, and Judith Seymour, non-executive director. Otherwise, I believe we have everybody here, unless Richard or Louise can see anyone else who's missing that we were expecting. But I think we are. We're certainly quorate, and we have good attendance today. So thank you very much, as we always do. Okay, well, it's my last formal meeting. I'm sure we'll come back to that. So let's make it a good one, and look forward to the discussions that we've got planned. So any declarations of interest for items on the agenda? Okay, I'll take that as none. Minutes of the previous meeting, 31st of July, which is paper A. Can I just check with colleagues if there are any points of accuracy? If there are none, we'll take it that we're happy to approve them. Okay, everyone happy to approve then? So we'll note that. Are there any matters arising that anyone wants to highlight before we get to the action sheet, which obviously has some specific actions? Okay, none. Thank you. So let's look at the action sheet. It's paper B, and most of the actions, I think a couple of them are from the last meeting, and we've also got one that relates to a previous meeting. So I think the first one, FT 2574, and I think we were thinking that it might be helpful. I don't know what the rota is for the care delivery pathway presentations, but it would be really good if we've got the directors coming along, obviously, to present on a particular story. If we could have an update, I think that's what we were sort of reflecting, that we could have an update on the last story that they presented. Is that okay? And are you happy just to build that into the format that we take forward? In which case we can pick up the feedback and follow up on Barry's story next time James is with us.
Absolutely. We discussed it in our director forum yesterday. So people will be giving an update on the previous presentation at the beginning of the new presentation. So I think that should work well. It should give some sort of join up, and there's 4 presentations, so they'll be repeated, so you'll get them reasonably quickly, the update from the previous one.
Yeah, thank you. And we may not always have a reason to update, but I think in that particular story, there were some interesting things around training
Yes.
and roll-out training and things like that. But it would just be interesting to understand what impact that has. So we didn't want to keep it on the action log as a sort of outstanding action for any length of time. Just wanted to make sure we were clear about the process. So if that's agreed and everyone's comfortable that that will meet the need, then are we happy to close that action and pick that up in due course as care delivery pathway leads come back to us in effect. So we close that one. FT 2584. I think that one is just something we agreed for the board development plan, Richard, isn't it? So are we able to include that on the plan for, because I think this is about a joint development session, isn't it? So are we able to include it on November's agenda,
Christian,
do you
yes,
think?
certainly. As far as item 84 is concerned, yes, we are targeting the November joint workshop. So that could potentially then be closed on the basis that we've got that in plan. And similarly, turning to the next action, which is 67, that's also scheduled for discussion, albeit at the NHFT board workshop, where we consider the results of the effectiveness review. That will happen in October. So similarly, if we're comfortable, we could also potentially close that action as well. Thank you.
Thank you. So we've got those scheduled. Our colleagues content that we can close those two off. Yeah. Okay. Thank you very much. So we will do that, and that there are no other outstanding actions. Also, just note the annual forward plan, which is obviously available for board member review at every meeting. I think we've covered, not aware there's anything we haven't taken at today's meeting that was scheduled to come. So unless there are any comments that colleagues want to raise about paper C, I think we can just note that. Everyone happy to do that? Okay, good. Thank you very much. Well, I'm at this point then delighted to hand over to Anne as our Chief Operating Officer, just to introduce the pathway story, and then I think welcome Adam to the meeting as well. So over to you, Anne.
Thank you, Krishni. So this month we are having presentation from the Mental Health, Learning Disabilities and Autism Pathway. And I will hand over to Adam, let him take us through the presentation, and then we'll have time for questions, and hopefully it'll give you a good sense of what the pathway does and how we work for our community in this area. Over to you, Adam.
Good morning, everyone. Hopefully you can hear me, and hopefully you'll be able to hear the audio on this as I go through, because we've got a video in it. Thank you for inviting me. In a strange quirk of fate, I think actually this will probably echo some of your thoughts, Krishni, around how we follow up on stories into this group and how you hear the progress of services and how services develop. So by means of introduction, I'm Adam Smith. I'm the Director of Mental Health, Learning Disabilities and Autism for NHFT. Mental health nurse by background. I've worked in the trust a little while, let's just say. Anne and I are growing old together in NHFT, which is lovely. We wanted to come today and talk about our memory assessment service, and we wanted to talk about it not just as a single journey, patient journey, but as a service journey, because of the fantastic work that the staff and the teams have been doing, particularly in collaboration with our wider community, particularly reaching out and really engaging through co-production with our carers, service users and experts by experience. And you previously, I think, had a presentation from Nancy, who is the service manager, around the same day assessment service that they were doing. This is actually the next step. This is the next innovation and iteration, and it will show you the journey that team are on. And you'll be able to see why I think it's so important to be able to present it here. So just a bit about us, the Mental Health, Learning Disabilities team. I provide the leadership function for all mental health services across NHFT. I also work as the Deputy SRO into the system, supporting Anne with the collaborative. So we've got those strong links back into partner organisations and back into the wider partners within the system to think about how we develop services, not just based around NHS providers, but based around the myriad of third sector providers and support agencies that are out there that deliver such brilliant care and compassion. And you'll see why that's important as we go through. As I said, the ethos around all of this has been co-production. The changes that the team have made are testament to their own passion, skill and expertise in driving this forward, but they're also testament to the voice of the community and our service users in how we deliver services. And this is specifically about our memory assessment service. So this is the service that our older adult population come to when they're referred by their GP, when they've got some cognitive deficits, they've got some memory issues, and they're starting to have some concerns about whether they might be moving into a dementia diagnosis, and we look to support them with that. We work. The over 65 population in our county is about 140,000, and in the next 10 years, it's expected to rise by 25%. So already we had services that were under pressure, and we had to think of new and innovative ways of supporting them. And I think the stark reality of this for me was that from initial concerns of a loved one, carer or service user through to getting a diagnosis could have previously taken anything from 16 to 20 weeks because of the nuances and the way that the system it was set up. And that's about needing certain diagnostics, certain scans or blood tests, and bringing all those results together in one place to then be able to make that diagnostic profile to be able to tell the family. And that's a very long time of uncertainty, best part of 3 months when you're in a progressive disorder and not knowing how to get that help is a really scary time. So we know that the number of referrals to the memory assessment service is going up. We knew that was leading to greater wait times. And we knew that through our work in Rushden, which is the presentation you will have heard of previously when Nancy came, that actually there were ways of doing things on the same day. If we could get everything together in the one place, we could bring the carers and service users in and really help them on that journey much quicker. So we put a bid into NHS England in early 2024 to work with partners in the county. And this was particularly working with the new Corby Diagnostic Centre, and then looking at the Alzheimer's Society and Northamptonshire Carers, but also thinking about how we linked with our global majority communities who are underrepresented in this world, actually. So quite often, and you'll hear on the video later about how we're engaging, but I was talking to Nancy this week about it because she's going out into our Sikh, our Hindu, our Black African communities to talk about dementia. And it's very much still an area of mental health that scares a lot of people within those communities, and it's an area that we see is dealt with within those communities without coming to mental health services quite often. So quite often they will avoid diagnosis or avoid coming forward because of fear, or because of not understanding the processes, or because our services quite frankly aren't right for those populations. So this is giving us a real opportunity to think about how we nuance our services to really meet that need of those global majority communities and those people that we don't see coming through our front doors. The changes were born out, as I've said, of feedback from our service users. So we're really good in NHFT at getting excellent feedback from service users and carers, but turning that into action. So not just allowing that to sit there on the shelf, but listening to what people are saying and understanding what needs to happen. So we recognised from our partner organisations that they were managing people in crisis who were awaiting dementia diagnosis. We saw the aims in the long-term plan. We've got service user reference groups, memory hubs, community-based support groups, all feeding in and telling us that there was a need to do something different. And so we set up a system-wide project group looking at establishing particularly the capacity of scanning. So the two sort of big areas that were a trouble for on-the-day diagnosis or even short-term diagnosis was the ability to get an MRI scan or a CT scan. So the ability to go to hospital and have a specific scan. And if you think about it as someone who's moving into a position of confusion and is reliant on your care or a loved one, you need someone to help you get there. You need to travel to multiple appointments. You need to go to busy hospital environments. You then need to wait for those results. Sometimes those results can take 2, 3, 4 weeks or more to come through. Then someone's got to collect those results with blood tests, have a diagnostic discussion, and then come back to you and lead you through your diagnosis. So lots of movement around the county, not great for the patient journey, an opportunity to fall through gaps. So we looked at the population outcomes. We looked at our population need to increase our diagnostic footprint. As I said, we thought about our ability to work into our culturally diverse communities. And we thought about that more personalised, better experience for people being as a single point of care. And we even considered the NHS net zero ambition about how much we ask people to travel, how much we ask them to move across our county, use our resources, use patient transport, and how we could work on that. We also knew that with the coming on of the Corby Diagnostics Centre, that there was a real opportunity to work with them in partnership to have some focused diagnostic sessions with them where we could book 8 to 12 clinic appointments on a Monday, bring the service users in, sit with them, go through the process and move things through at a much faster pace for them. And actually it's a much quieter environment in a place where there's the availability of easy transport links and parking and all those things that are actually really important when you're moving into this space. So that's our journey. Commissioner discussions in early 2024, and then the project group formed, and then really moving through to only just opening in July. But when you, and it's a shame Nancy couldn't be here, but when you hear the passion and the interest from the teams, it's amazing how much in just the last 2 months people are seeing that great patient journey. They're enjoying being in the work environment, and we've already had more than 91 service users come through who are now receiving a diagnosis within a week. So the point of referral from a GP to getting an initial diagnostic appointment in the CDC is around 4 weeks, but actually because it's working so well, it's coming down to about 2, and then that will be a Monday appointment. With the results back by Tuesday, with a team discussion on a Wednesday, you're brought in for the next Tuesday to get your diagnosis and meet the team to support you. So a distinct timeline. And again, when we're thinking about how we deliver that to our communities that perhaps don't understand or can't or aren't familiar with the way the NHS works, it's almost a distinct package that you can deliver and say, this is it. This is how we can work through your anxieties or your concerns about it. It's a phenomenally good service. We are continuing to review it with the University of Northampton. Professor Parks is supporting us with that, so we'll have a formal review by the university on the work that we're doing. It's only been in operation 2 months, but already we're looking to roll it out from Corby into the Rushton team and wider older adults teams, because we're seeing such a good flow of patients moving through that we need to continue to fill the spaces in the scanning departments, which is a good problem to have to some extent. And we'll continue to review the service and you explore the outputs from it with our lived experience and service users through those co-production groups. Any questions?
Thank you, Adam. And before I bring colleagues in, I'm sure there'll be lots and lots of comments. It fills me with pride, and thank you for sharing that story. And I think for those of us who heard we had the positive experience of having, I think Nancy and Farida and various colleagues came to the meeting probably a year ago, maybe. I don't know exactly when, but it's really good to see exactly what you said at the beginning, Adam, the continuous improvement. So we heard about what we'd done to improve our own internal processes by introducing, I think they called it the one-stop shop at the time in Rushton. Right. And now then to see the sort of integration and the use, the kind of the multi-part, multi-agency aspect of this with the CDC. I think that's incredibly powerful. But what really shines through is the sort of compassion and care that is sort of built into everything. And I think particularly, I'm sure I reflected this to Nancy at the time, but my mother had dementia many years ago, this was now, but she was also physically disabled. And the combination of that just made it incredibly hard for us to put her through what felt like at the time, and this was sort of 10 years ago or whatever, a really demanding, confusing process that even physically having to navigate, let alone the confusion. So I think something like this then would have been amazing. And this wasn't local, by the way. This was in Surrey at the time. But it just goes to show what we can do when we, work well together. So fantastic story. Thank you.
I do think I think your point about what we can do. It would have been easy for the team to say we've got the same date, the one-stop shop, and the diagnostics bit is out of our control, and so that's what it is. But actually, they haven't stopped at that, because they've heard the stories like your own about that patient experience, and they knew they needed to push on things in a different way. So yeah, it's brilliant.
Thanks, Adam. There's loads of people wanting to come in, so I'll bring them in, and any questions, obviously, back to you. Angela, please.
Yeah, thanks, Adam. And I was pleased to hear you say how proud you felt, because you should feel proud of it as a key leader. And I know there'll be many leaders involved in this, but as a key leader in enabling what you've described today, I think it's exemplary. I really do. I don't think you would come across many more examples that really are as person-centred, as compassionate, that are about integrated care and partnership working, continuous improvement, co-production. You've said all those things, and sustainability coming in, and evaluation. I mean, everything in there in terms of how we want to improve care for our local population. I think it is absolutely exemplary, and as everybody said, I'm sure everybody feels that, that's what you'd want for all of your friends and families who need to undertake and use services. My question is about how we are using this learning within the organisation, because clearly it's a good example of how we can work differently. How we're using it to share with our ICB partners in terms of the population, health and wellbeing boards across our group, and of course regionally and nationally, in terms of that, option that people may be pursuing already, but equally we may have some leading opportunity here. So just interested a little bit more about that, how we're spreading the learning and sharing the practice, because we'd want others to experience this too. Thank you.
Yeah, so and thank you for your comments. I'll pass them on to the team. The team has driven this, absolutely. I think 2 months in, we need to get the response from Jackie and the report from Jackie, but I think there's elements of the elements of the learning from this aren't just around this service. They're around that, to some extent, for me, that neighbourhood model of and that localised model of working either with a particular diagnostic category or a particular subsection of the community, and how we can mould our treatment, our care, and our provisions to meet that. So we're thinking about how we can similarly nuance our services as we move our CMHTs into our community mental health teams into those transformed neighbourhood teams, pulling together the data that says this is your population for your neighbourhood, not the one you're working with, but the actual population. So how can you now go and work with that neighbourhood and do just this? Think about the services you deliver, but how you adapt them to that community. And we've already been doing some work in Wellingborough with at the Hindu Centre, reaching out to them and thinking about how we introduce mental health and community mental health services into those areas. So I think the backbone to this for me was getting it right down to a person level and adapting for that person. I think I can share that. My aim is to share that learning across all of my mental health services and think about how we do that in inpatients and our community. I take on board your point about the wider system, and I think as we develop the learning from this, we do need to think about how we share this with the region and more widely, because it's not a secret you want to keep, really. It's such a good piece of work.
Brilliant, thank you. Jo, please.
Thank you. Many congratulations, Adam, to you and the team on the work that you've done. Fantastic achievements. I won't repeat all of the stuff Angela says, but I completely back her assessment of that. I'm interested in how you've used the facilities that you have at Corby as the test bed, and wondered whether the importance of a physical location is part of that transformed service, because it allows you, as you say, to pull all of the partners into one place, and how we could use perhaps existing opportunities, whether it's through GP surgeries or other community facilities, to establish those hyper local hubs that you were talking about.
Yeah, so there's a second diagnostic centre in King's in Northampton. I think you're absolutely right. I think the provision of it's a brand new, nice environment. It's quieter. It's got those, it's got those diagnostic abilities. Bringing it meant that we needed to move and be in that space, which is great. But it does bring it all into that one place, and it feels, if I go to hospital, I want to go from one room to another room to another room and then be done. And this is kind of that space. So I think it just echoes that need to navigate those partnerships and bring everyone together in that. And actually, I think as an organisation, we've got a really good history in doing that. Our crisis cafes, our integrated response hubs. There's lots of bits in mental health where we're really used to working in partnership in the same location, under the same management team, sharing our policies and our procedures. I think we've proved ourselves to be really good at that. But I think you're right. There is something about that geographical location, and I think that's the bit we need to play back into the ICB at times. Yes. Is when we're thinking about recommissioning services, we need to think about that partnership option and what's the best that we can gain across all of the organisations. And it's incumbent on me to make sure that I shout about mental health as loudly as I can within that, because sometimes we get a little bit lost.
Yes, no, I completely agree. Thank you.
Thanks, Jo. David, please.
Thanks, Krishni. Adam, as with everybody else, that was really powerful and really thought-provoking. Not a question for you, but a kind of comment and an offer, which was, you're demonstrating a lot of the work we're doing around population health. And I think the point you just talked through earlier was about the fact that it's not the population that come forward, it's the population of that geographical patch that we need to reach and access. And that's a lot of the work that NHFT is trying to do. I think, building on Angela's point, if we can help you tell the story to others and share the experiences inside the organisation, that's great. And I was just sitting there thinking, actually, we can connect you with NHSE regional colleagues in mental health who would find that video really powerful. That would help take it forward. And linking stuff back to our strategy, you really have talked through today about including everyone, about building healthy communities, and all of the things that we refreshed our strategy and set out at the beginning of April to say we would do differently. Here is some really good evidence. And the final bit of my reflection is, it would be great if you and I could have a conversation, talk to Anne as well, about how can we capture the things that different services are doing and present it back and show to the ICB and others how we are making a difference to the population by reaching out to people who haven't always been engaged and take things forward. I think that would be a really powerful narrative across all of your mental health services, build it into physical health as well, and not just the service you've demonstrated today.
I think you're absolutely right. I think the really important thing for me, and it sticks in my head, is that if I move to neighbourhood teams with my community mental health teams and my mental health services in general, if I move into those neighbourhoods and deliver the same services I'm delivering now, I feel like I've got it wrong.
Yeah.
Because I haven't changed. I've just taken the same thing and plonked it somewhere else. So I, and that's in my head. I know that we need to nuance things differently. That's the game with the neighbourhoods way of working.
Thank you very much, David. Tim, please.
Yeah, just very briefly for me, Adam. Well done and congratulations to the team. I think it's really impressive. Just a couple of things and observations from what I've seen both in this presentation but on the ground as well. There's an energy and enthusiasm to this, which is palpable in the team, but there's also a tenacity to make collaborative working work. And quite often we kind of don't think that's an important skill set. It's kind of just do the process, do your work as hard as you can. But actually this ability to challenge the status quo and a tenacity to see it through, which they've demonstrated in spades, is really powerful. And if we're going to make true collaboration work, then actually trying to challenge how we've worked historically is so important. So well done, congratulations.
Yeah, I agree, thank you.
Thanks, Tim. Duncan, finally.
Yeah, great presentation, Adam. Great examples of person-centered care. Like Krishni, I had a mother who was going through a similar diagnosis, and indeed Krishni in a similar county, in the same county. And the service has changed beyond recognition since then. The thing that I'm mindful of is not only are MRIs a precious tool, there's a great demand for access to them, and you've really demonstrated here a very efficient access to them, but they're also a very scary tool for the patient. And the compassion that was shown in the video struck me that you're probably getting a far higher toleration of the whole process from visit to actual investigation. I was wondering whether you keep an eye on that, how well it's being tolerated now as a diagnostic tool compared to those patients who weren't able to go through it before.
Yeah, one of the things that the team do as part of the initial triage is to think about whether the person is going to be able to sustain or cope with an MRI, and that might need an initial conversation. You're right, they are noisy, and they're pretty scary really. And I think because it's a quieter environment, because we've got that person-centered approach where you're met, you've got the video, we can have the discussions. It's very different to sitting in a queue in a radiography department where someone comes in and says, can you just sit on there, and you end up doing that without no. If you didn't tell me, I wouldn't know what an MRI was until I was in it. And then once you're in it, it's loud and it's horrible, isn't it? So I think you're absolutely right. I think there was a greater level of dropout. One of the things on the evaluation that Dr. Parks is doing, I believe, is that she's looking at our dropout rates of people coming for those assessments. We're also recognising the value of those appointments, which is why we're starting to think about pulling other teams in. We don't want to have 12 appointments on a Monday and only have 6 people in, because that's not helping the system. So we're trying to move other cases across as well, just to make sure we get the best out of those appointments. But I'll make sure if it's not, I'm pretty certain it's in the evaluation. If it's not, I'll make sure that we look at that from a system approach.
Brilliant. Adam, thank you so much. I think that was incredibly powerful. I think, as David said, it really sort of resonated for us all, because it demonstrates so much of our ambitions in our vision and mission and our Thrive strategy. I genuinely, I think once maybe the evaluation has been done as well, it would be a even better story, a more the complete story would be really amazing for us to submit various sort of submissions or articles or research papers or whatever, really getting that out there, I think would be great. In the meantime, though, that video tells a brilliant story now. And perhaps one option, we've got a new ICB chair coming in who might be very interested in seeing that as a sort of example of some of the work they're trying to do, and that might be a good opportunity to sort of raise the profile of some of the work. But on behalf of the board, if you could please pass on our thanks to the team.
Of course I will.
But I think they might have been up for a quality award before, weren't they, for the work they'd done on the one-stop shop? Because I remember seeing them at the quality award ceremony. I think Farida might have won Clinical Leader of the Year that year as well, if I remember. So that it's fantastic. They've kept their foot on the pedal. And I think that's the sort of example of leadership that we really want to see. And thank you to you. I'm very glad that you're getting old with NHFT, because you're also doing a fantastic job. So thank you very much, Adam. Great to see you. And thanks for sharing the story.
Okay,
all
I'll
right.
leave this to the rest of your meeting. Thanks. Take care.
Thanks, Adam. Bye. Okay, well, what a great way to start the meeting, yeah, great to hear that sort of sense of progress as well. And I think from the last story we heard from Nancy and colleagues, so brilliant developments. Okay, we move on to item 8 then, which is our risk paper and our risk section. So Richard, over to you for paper D then.
Thanks very much, Krishni. So yes, regarding our risks as a board, you'll see in this month's report that our highest scoring risks remain those concerned with delivery of our in-year and medium-term financial performance. This is clearly consistent with the conversations that we've been having as a board and in committee. 3 of the risks we're managing on a slightly more positive front have now achieved their target risk score, which is good progress considering the start point at the beginning of the year. And you'll also note that through the report we're proposing to move one of the risks that concerning our partnership ambitions to manage together with LPT as a group, and that will feature in this afternoon's discussion at our group board meeting. In previous board meetings and indeed at committee meetings, we've talked quite a bit about the need to populate the linked operational risks section of our board assurance framework. Work is well underway on that, and committee members can expect to see the first sort of revised iterations of those reports coming through committees. So certainly by November board, we'll have a fully populated operational risk section to our BAF. But I just wanted to note that in public here that work is well underway. And of course, this is just about the presentation of operational risks. Clearly, the management of operational risk is very much in hand. The only other thing I wanted to point out really in this month's report is just a reference to the 2 new risks that the ICB has identified since clustering has started, and these relate to the delivery of both the national reforms and also the delivery of our local strategic objectives. So I think in the interest of time, Krishni, I won't say any more about the report. Happily take any questions or comments. Thank you.
Duncan, please. Thank you, Richard.
Yes, thank you. And thank you, Richard. I just wanted to take the opportunity to thank Richard and all the executive directors who contributed to the audit committee and audit and risk committee workshop we had last week, where there was a really positive contribution from all, in particular looking at that point that Richard's highlighted for us, that joining up of operational risks through to the board assurance framework and giving us a far clearer view of how we're looking at risk from ward to board and back again. So a big thanks from those of us who participated in that. Thank you.
Thanks very much, Duncan. So I think in the only reflection I had, and perhaps we can pick it up as part of the discussion on integrated organisational report, and then subsequently when we talk about finances later in our confidential meeting as well. But it is important that I think we reflect the BAF 3 and 4, which are the 2 that Richard alluded to. There's sort of, there's no movement yet on those. And I think we just need to, as a board, recognise that we need to see some movement on those in terms of reducing the risk around that as the year goes through, because otherwise there is a sort of challenge around that. So can we just pick up sort of clearly when we get to the integrated organisational report, sort of the actions in hand around value programme, etc., that might mitigate against some of that, which I think will be important. So I don't necessarily want to talk about that now, but if we could pick that up when we talk about the IOR, I think that'd be helpful. So thank you. If there are no further comments, we'll move on to the strategy section. We've got environmental analysis to include update on service visits and health and wellbeing board. So we'll start with Angela and then over to Dave and any other executive directors who want to comment. So Angela?
Did you want to pick up winter planning with?
Oh, apologies.
first,
Yes.
yeah.
Yeah.
Hello. So yes, winter plans are fully in process, as we have discussed at previous meetings. Since the last board, we have submitted our system winter plan to Region. We've had 3 stress testing exercises at different locations to work through our plan. We've had very positive feedback from regional colleagues regarding the plan. Obviously, with the Tracy, that we now need to deliver the plan, and we don't fully know what's in front of us, but that we're in a good place, or a better place than we have been previously, preparing for winter. What that means for NHFT is that our plans set out to board in July around increase of P2 capacity at Spinney, increase of UCR, our urgent community response, through our ICT team has been increased, and also some sort of small changes to our dementia and delirium part of the pathway, which is part of a wider partnership pathway. This has all been accepted and is in process. So now that we've done the final national sort of submission, I'll be able to circulate the system winter plan, which has gone through ICB board. So I will circulate that for everybody. It wasn't quite ready in the system for this meeting, but it will be available very soon.
Brilliant. Thanks, Anne. Any questions around any of the update that Anne has provided? No? Okay, thanks, Anne. Apologies for overlooking that, moving on too swiftly. So, Angela, over to you.
Yes, just a couple of things to mention outside the Chief Executive report, but just remind everybody that with our cluster arrangements as an ICB, LNR, the move towards a shared leadership team is now finalised, and that means that we will very imminently be in a position of working with individuals working across that cluster arrangement, and we will be obviously considering that and its implications for us. I think importantly to signal that Claire Murdoch as National Director stepping down from the role, I just would want to put on record mine, Krishna's and all of our thanks for her role and contribution to our sector over many years, and incredibly important, I think, to acknowledge that here and to recognise that. And then I think just to mention, I will touch on the NOF ratings in my report, but just to say I think we have seen some effect in the mental health sector generally, and that's something that I think is being looked at in terms of the metrics and their sensitivity or development that's further needed in the mental health sector. So important just to keep close to that. And I'll leave it there. Thanks, Krishni.
Thank you very much, Angela. Dave, did you want to come in at all on anything from recent Health and Wellbeing boards or any other matters?
Thanks, Krishni. Just to update, and this plays into the resource risk that we've identified in the BAF. The framework for neighbourhoods is now developing at some pace. I mean, obviously in Leicestershire, there's a national pilot site in place there, but the Health and Wellbeing boards are reviewing the Integrated Care Board's ambition for neighbourhoods, and that's on the agenda next week. We play a leadership role in that, so we're supporting them in their presentation. And in due course, we expect to see that begin to illustrate and highlight how relative resources, the shift from acute to community is enshrined through the neighbourhood model of working, and that picks up some of what Adam described with the community diagnostic centres operating in a very place-based way to support pathway development. So just to highlight that as something the Health and Wellbeing boards are looking at in earnest.
Brilliant. Thank you, Dave. Anybody else want to come in? Any other general points? No. Okay. Thank you. We'll move on then to the Chair's report and the Chief Executive's report. So I'll take the report as read. Obviously wanted to, as part of the report, welcome Natasha, as we did at the beginning of the meeting. And there are a number of other points to note regarding sort of, steps like Councillor governors, developments, etc. Particularly wanted to highlight the annual public and members meeting. Thought it went really well. We got some really positive feedback from colleagues about it. I don't know, Richard, if we got much more in terms of the evaluation results. We don't always get a lot of feedback through those mechanisms, but we certainly had a very nice note from one of our staff members who was a staff governor, who really commented how far it had developed and how positive the governor input as well was. So that was really good, and particular thanks to all colleagues who were involved in pulling that all together. And really just want to take the opportunity to thank colleagues for their support. As this is my last public board meeting, I did want to put on record my thanks to executive colleagues and NED colleagues. I know we've got a bit more time in private, but it's been an absolute privilege to chair this board, so I did want to acknowledge that. But I also wanted to give the opportunity, in case there are any of NED colleagues would like to highlight. There's always a fantastic list of activities that people have taken part in. So is there anything that any of our NED colleagues want to just highlight that they've been involved in that would be really interesting to spotlight? Julia?
Thank you, Krishni. Just a little example from a recent service visit to Brookview ward up at Berrywood Hospital for its award for older adults mental health issues, and the enthusiasm of the staff was infectious. And they'd recently applied to the Royal College of Nursing for an external fund to support an initiative that they'd come up with of some grab boxes. So when patients become distressed, they need activities, they need things to distract people and to have a safe space to calm down, etc. And they've got about 20-30 odd boxes full of all sorts of different things spilled over into the matron's office, all over the floor. It was wonderful while they were constructing these things, but it was just a sheer example of somebody going over and above. It's not routine care, it's completely comes from a point of compassion. And they'd done it in their own time and submitted a bid and, been very successful nationally in achieving the money. And it was just a fantastic example. And I think just wanted to shout that out, really. Other wards are doing similar things, but they're about to share that innovation across so that people have learned from it. But it was just, I couldn't not just say today, that was a fabulous example. Thank you.
Brilliant. Thank you, Julia. Melanie?
Yeah, a completely different example, actually, than Julia. I attended an internal meeting, the Strategic Transformation Group, which is where the different service leads, operations and corporate and enabling teams come together and share really the transformation programs that are ongoing, a very supportive environment, a very sort of great environment to sort of just fill you with, I think we've used the word already, but pride about the amount of effort that's being put into transforming services, both for patients, but also critically deliver against the strategic needs for efficiency and productivity and financial value as well. So just a really informative meeting to attend. So just wanted to raise that one.
Great, thank you, Melanie. And finally, Duncan?
Yeah, also in that line of service visits, I had the pleasure of accompanying Anne to Wheatfield Ward, and one of the things that stood out for me there is the efforts that staff on the wards are making to make it homely. What particularly stood out was the use of art, and in particular photographs being produced by residents on the ward, and how they were there. And almost every picture we looked at, Anne, had a story behind it, which the staff were able to tell us about and see how this meant things to people on the ward. That was really good. We've also just had a service visit to Manfield Court, and that some of that learning from Wheatfield about how it's made homely, I think we'd had a good discussion with Paul and members of staff there from the Children's OT team, and how we can take some of that and hopefully bring that to become a more welcoming and homely place for our visitors there. Thank you.
Thank you very much, Duncan. Really good examples of things that are happening across the Trust, and always good on our visits to see them. So thanks very much for sharing. So I think that's just my report for noting, and I'll hand over to Angela for her Chief Executive's report, please.
Thank you, Krishni. And important people will see the staff report where we're talking about the new NHS oversight framework and its challenge of ranking and rating organisations across the NHS, which it has achieved. So we've got a Q1 result, which is really pleasing in terms of segmentation position. And I just would want to say a big thank you to everybody for that, because clearly there's access, metrics, people, performance, finance. It is a combination, and nobody achieves this on their own. It's an organisational position, which is really important, and we welcome that. We recognise it's a relative position and things will move, and we recognise that the oversight framework will also seek to develop through the year and into next year as well. So, but an important step for us, and I think again a signal of a strong foundation from which we can build further. So I just want to just draw attention to winter vaccination, and obviously Jan has talked about winter planning, but just to remind everybody that, you know, flu vaccinations, COVID vaccinations are a collective action. This is going to be so important to act as a prevention and an opportunity to take vaccination and to make a difference. And I know that Linda and the teams are working very hard to understand how we support our staff with that, but obviously we can also encourage our family and friends to take on that vaccination and contribute to the prevention, which it does make a difference and can make a difference. So important to share. Equally want to say thank you to everybody for the annual meeting. A lot of work goes into that, clearly because it's work that reflects across the whole year, but also our communications teams do an awful lot. Our governance, OD, everybody pulls together. It's a team effort, collective effort that lands that. And as you said, Krishni, it was great to participate and to always, you know, look back and reflect forwards is always a fantastic opportunity that I really enjoy. Want to draw attention again to our baby friendly gold accreditation. This is something that's very close to my heart. I am the exec sponsor that supports this baby friendly work, and I can confirm that I was interviewed as part of this accreditation process. But it's really great to get that gold acknowledgement, because that's a reflection of the team working and integrating across our 0 to 19 services, across partners, and also understanding their role in prevention, because this is clearly prevention work and outcomes for people's futures that we recognise here. And I'm really pleased to say that as part of the group work, I'm also the baby friendly guardian and lead over there. And again, sharing that learning across, LPT are also going for gold accreditation. So it's really important example of learning and challenging ourselves to go further. Again, we've got lots of awards that people will read within the report, but obviously the first trust across the country to win the Outstanding Gold Food for Life Served Here award is something that, you know, I do want to shine a light on. The fact that we are, you know, absolutely striving for excellence in every part of every corner and starting to understand the difference we can make in all of our services, I think is reflected in this award. So thanks to everybody who contributed towards that, and the achievement is a really good one to see. And then finally, I just wanted to, as Krishni said, draw attention to the fact that this is Krishni's last public board, and as you'll see in the reports, this is clearly a significant milestone for us as an organisation, not least because of the many years that Krishni has contributed to us in NHFT, and clearly it's been a very positive improvement journey that has been held, and we've got many examples of the contribution through that time. But what I would say is that in summary terms, we've had a value-based leader. We've had somebody that's prepared to be a system leader and to work in partnership and to influence and constructively challenge, which is very significant indeed. We've clearly had somebody who's prepared to understand that their role in influencing at regional and national level. And personally, I know that she has always understood that people matter. I think that's really important to convey as we end your milestone here at NHFT, Krishna. I know it doesn't finish today, but publicly it does. And I think from a personal point of view, you know, a chief exec and a chair relationship is a really important one for an organisation, very important. And I know all the regulators understand that. And I have to say that the personal support that I've had in managing, you know, the period of time over many years is a significant one. So thank you, Krishna, and we will miss you.
Thank you, Angela. Thank you very much. It's hard to respond to that because it's, you know, it's, but as I said earlier, it's just been, it's my privilege, to be honest. I've absolutely loved being the chair of this organisation and still feel very proud of it. And I think whilst there are people in this organisation that I care about and I've known for a long time, I will be a friend of this organisation for many years to come. So I fully expect to keep in touch with everybody. But thank you for those kind words. Okay, well, let's move on to the integrated performance report. Integrated performance section. First of all, it's the AAA report from the Performance Committee. Julia, thank you for stepping in. I think you're going to try and cover what you can through that. And you were part of the meeting, so thank you.
Thanks, Krishna. I can't follow what you've just said anyway, so it's very hard to follow Angela's tribute there. I'm sure we'll be doing that throughout the meeting in the next month, but absolutely echo Angela's words. Thank you. So this is Judith's report from the Performance Committee. We'll take it as read. There were no matters to alert. A couple of things just to highlight in the advice section, particularly around financial issues. And as I say, you take it as read, but the month 4 position is outlined there. And of importance, really, Judith's words around numerous challenges to achieving break-even plan at the end of the year. And we spent a lot of time looking at that and, you know, paying tribute to our teams across the entire trust, not just corporate support teams, finance teams, but all our teams, for looking at ways to, you know, help improve our value programme. And we felt it's important, particularly around the medical workforce, to look at that in detail, particularly around staffing, safety, the value programme, and look at our agency reduction contributions. So that's our financial position at the moment. We looked at the medium-term financial plan and again outlined some of the risks for the next couple of years, and then again had an update on the group value programme. In the Assure section, we had a really comprehensive overview of the start of our Nottinghamshire and Lincolnshire prisons onboarding, particularly around the first one, which was His Majesty's Prison at Loudon Grange. And for me, what struck me was the holistic view we take when new services join us, and it's explained there. We look at finances, employer relations, medical and clinical transformation, regulator relationships, and we've taken a lot of lessons to date, even from that first service. And I think that gives you a view of how we you know, onboard new services. The integrated organisational report, which we'll come on to next, I know in the board meeting, we had an opportunity to look into that and continue with concerns around our wait lists. But we'd already had at the last committee a deep dive into the 6 or 7 services where they have the longest waits, and we're looking at productivity and efficiency work in those services. The value programme review is laid out there. We had a really important digital update with first really comprehensive update of all our digital management and activity across the organisation. And we approved one policy, the digital acceptable use policy. There's also the workshop summary slide. We had a fantastic workshop on a couple of areas, the new Procurement Act and the impact for us as an organisation, our green plan for the next 3 years, and measuring outcomes for patients, and how data will help us drive improvement in the future, and how we can incorporate that in the integrated organisational report. So if anybody else wants to add anything to that, that would be great, but that's the summary from the Performance Committee.
Thank you, Julia, covering it so ably in Judith's absence. Any comments or questions regarding anything in the report? I know we're going to come on to the IOR shortly, so we can pick up anything there as well, of course. Okay, I just really want to say, I think these, it's really helpful to see the feedback from, I know we've had this before, but the feedback from the committee workshops, and I think the process of committee workshops, you know, Duncan's mentioned one earlier as well for the Audit and Risk Committee. These seem to me adding a lot of depth and appropriately when we need to explore issues in a bit more detail, and I love the way we're giving the feedback back to the board about those, and not just the sort of reporting the minutes, if you like, and the assurance. So really helpful practice. I think that seems to me very good practice that we really welcome from a board perspective. So thank you. So we move on to Integrated Organisational Report, Paper H. Dave, should we start with you? Although I guess there might be other colleagues who want to support you with that.
Great, thanks, Krishni. So I'll just cover the key themes that emerge in month 5. The report is there with further information. As Julia said, we look at it in an expanded form in the Performance Committee. Angela's covered the segmentation. I'll talk a little bit about that in the executive summary, but positive news and a good basis for us going into the rest of the quarters of this year, but also into planning for 26-27. Just to comment on planning for 26-27, we now expect planning guidance to arrive sometime in October. It was originally end of September, but we are expecting it then. That seems to be the national commitment. We have stood up our planning framework in the organisation, supported by our business, our strategy and partnership team, and of course our transformation and BI teams equally, along with workforce and finance, so that we have a triangulated plan in development aligned with clinical priorities, and that will pick up some of the BAF expectations in terms of both productivity gains across services, but equally where we've got a disconnect between demand and funded activity, we'll be able to use the planning framework to highlight those and begin to engage in system conversations with ICB and others in terms of mitigating any risks or challenges we've got in those services. So just to move through the executive summary on waiting times, as Julia said, it's formed a significant part of scrutiny from our assurance framework within the organisation. We are seeing a dip in waiting times from August 2025, which we're broadly attributing to it being kind of seasonal holidays, etc. But nonetheless, it does give an indication of heading somewhere in the right direction. And critically, of course, the numbers of patients seen with 18 weeks, which is the crucial quality measure that we're using to manage any kind of demand and risk that's inherent in that demand, is well within expected ranges. And we will continue to push through on that through a productivity programme, which we're initially focusing on those 6 service lines that Julia described. And we've got a set of rapid reviews in place for those services to identify where there are opportunities for improvement. We are seeing movement in some of our speech and language therapies with recruitment in place and waitlist management initiatives that have been successfully rolled out across some of our children's services. And we're also using some improvements in digital access, including the use of AI to support increased clinical capacity for face-to-face and patient contact care delivery. So that again is a really positive movement for us as a trust to be able to engage with those innovations for patient benefit. The other piece of work that we're doing that's linked to the planning framework is forecasting into 26, 27. So taking what we know to be demand and capacity issues across services, but beginning to now proactively gauge what that might look like as part of next year's planning round is going to be pretty important. And we'll be, of course, cross-referencing that with growth in population and growth in demand that we're seeing from increased numbers now of new families coming into the county with successful, urban developments, including, new housing in Wellingborough, Corby. We are seeing that now reflected in a slightly younger demography in some of those geographies where we previously would have seen a slightly different, predominantly frail elderly in many areas. Working through workforce, we have successfully managed to get our sickness below 5%, and work continues to manage that. We're engaging with staff side and network colleagues in terms of managing and overseeing that as a trust. Our turnover marginally increased from previous month to 8.3, but we have seen that tracking down significantly now, and it is below our trust level tolerance in turnover and below the national average actually for turnover in NHS organisations. So that's really positive and is an indication of some of the establishment review work that we've done as part of the value programme, making sure we've got the right people in the right roles and they're supported appropriately. Training and compliance and appraisal rather are within compliance levels, and we're continuing to explore ways of managing our bank spend in a consistent way to pre-COVID levels. And really important that as a board, that is not about us stopping bank usage, it's about minimising our spend on bank. It is a temporary workforce, that's the expectation nationally. We've got a good track record of this with agency, but we also recognise the importance of our bank staff to an organisation like ours, where we've got unplanned peaks in demand as per kind of the needs of patients as we find them. So we need to manage that safely, and safe staffing and safe services continues to be the golden thread through everything we do. I'll just highlight that we have had movement of similar to what we saw in agency staff, where we saw agency members of staff or people contributing from an agency to our services moving over to substantive. We are seeing a similar movement across bank to substantive roles where they're available in the trust. And again, we take that as a positive and we want to build on that. So thank you to all that have contributed to that work. Quality and safety, we are seeing all of our incidents reported within control limits. There's an ongoing weekly meeting with the safeguarding team for insight sharing. We also have a regular exec-led safety meeting on a Monday morning to highlight any emerging risks across the organisation, and that feeds into our safety management framework, which again is important. Next week we'll be looking at some of the cyber challenges that we're seeing and making sure that we've got appropriate business continuity plans in place across services. That's part of us responding to emerging threats that we're now seeing across the wider private sector, but increasingly in the public sector too. In terms of finance, I know colleagues will come in on this. We are broadly continuing to plan on a break-even basis. Further work is in place to manage our £24.3 million savings plan. As I've said in the workforce section, a lot of that is now focused on bringing down our bank spend from a high. It has been the highest it's ever been as an organisation. So we do know there's opportunities to reduce spend in that area, and that's what teams are focusing on currently. The oversight framework Angela touched on, and I think also referenced that we will see this now develop. We believe the framework is in place until 1st of April, so we will build on our gains in that, but equally aware that there will be changes coming in April in terms of how certainly this sector is measured, the mental health and community sector. We do view that as a positive development because there are improvements can be made, but really important for teams to feel like we've got a good foundation going into 26, 27. And of course, the recovery from COVID continues, as I've discussed in waiting lists. So it's really important to take these moments as a positive. Our length of stay work in adults continues. We are seeing a bit of a deterioration in some of our MSK pathways, which again are a strong focus of the Quality and Safety and Performance Committee's work, making sure that we're on top of waiting list management schemes in those areas. But we are looking at some of those weights are improved coding and cleansing of lists, etc., to make sure that the right people are in the right place. So again, it continues to be an ongoing improvement work, and the rollout of ILA, which I think the board had a presentation on ILA, possibly when it first came into the trust, which is part of our wound care management system. In terms of mental health and learning disabilities, really positive to note that we've got no out of area placements this month, which again is really important, not only for the quality of care that patients receive and their experience of it, and of course families and carers' involvement in that too, but equally it plays into our value programme and makes sure we're using taxpayers' resources as efficiently as we can. So just really complimentary to the team and ongoing hard work from the triumvirate leadership that's in place through Anne, Linda and Sachin, but all the way through the organisation, that focus on consistently trying to get the right length of stay for the right patients in the right place at the right time. Good movement in our talking therapies. Quality Committee keep us very focused on looking at outcomes, and our IAP therapies are a really good example of a service line where the outcome is really demonstrable, and we're again above benchmarks in terms of performance in that area. And then just to close off on secured services, again, we talked about this in previous updates, but good movement in terms of staff appointments. We've got a strong programme of service visits now emerging for new secured services as they come online. And throughout the month of October and into November, our Freedom to Speak Up leads will be persistently focusing on new services and our secured services specifically to make sure that we're able to support colleagues in changing contexts and new opportunities that emerge through those services coming on stream within the organisation. Thanks, Krishni.
Thank you very much, Dave. Very comprehensive and lots of positives there in terms of assurance. Any questions or comments from colleagues to add? Duncan?
Yeah, so it's now a good time to just comment on the finances coming from Dave's report, if I may.
Please.
Dave, let me first of all really acknowledge in the report and in the narrative, there is lots of evidence there of great work on the value programme. I in particular pick up the highlighting you made of the length of stay work, and it strikes me that this is really answering much of our auditors' questions about recurrent actions we're taking, but that it really focuses on our productivity. I think my question is, returning back to our external auditors' comments, our reliance on non-recurrent measures to hit our break-even target. So it struck me there was masses of great work by the triumvirate there, and it really is to great value for our patients. But we do need to keep an eye on hitting that break-even, and that we aren't forever relying on non-recurrent measures to get there. I wonder whether you or Paul could just comment on where we are on that.
Paul, do you want to come in?
Yeah, so just you remember the splits of the 24-25 value programme was around a third was recurrent, which is what you're alluding to, Duncan. And what we're seeing at the moment is that the plan at least has shifted, and we are now more 50-50 in terms of recurrency. So that has shifted in the right direction. All of the reviews that we are doing around the value programme, we are urging people to deliver on a more recurrent basis. So actually, I think there's more to come in terms of the plans that we have. I'll be perfectly frank, I don't think we're going to get to the point where we're in a position where we're 100% recurrent, of course, and we will always rely on non-recurrent schemes to a point. But I think, Duncan, that gives you a sense that we are shifting away from what we've done probably over the last couple of years, where we've been around the sort of 25 to 35% recurrent. We're now moving to the 50, and I'm sure by the end of the year it will be even higher than that.
Thank you.
That's very encouraging, Paul. I think, particularly if it's moved from, early, the kind of what we anticipated at the beginning of the year. I mean, clearly this is a big area of challenge. We recognised it would be, didn't we? Because we're trying to hit an efficiency programme that is of a level that is higher than what we've tried to do before.
I think it's worth noting just at this point, Krishni, that even with the plans that we have on the value programme as it stands, notwithstanding that challenge that you've described, this will still be delivery of savings more than we've ever delivered across NHFT in any circumstance. So I think the hard work that Duncan's referenced absolutely is paying off, and I guess like most things, as we get closer to hitting our target, it becomes more and more difficult to find those final schemes to get us over the line.
Thanks, Paul. Julia?
I've got a totally different point. I don't know whether Dave would put his hand up for that comment.
Yeah, Dave, so any more on the finances section of the report? Dave, is that what you wanted to come in on?
Well, just to kind of support Paul's point about the recurrency, non-recurrency bits, we have gone through a sequence now of effective grip and control measures in the organisation, which we're seeing kind of the results of through some non-recurrent means. But as we get into next year, we will now be increasingly looking at service reconfigurations, etc., to try and consolidate some of that into a recurrent framework for our finances as they go forward, and into a new neighbourhood model of working, of course.
Thank you, Dave. Julia, then back to you.
Thanks, Krishni. I just wanted to highlight something I actually brought out from this in the performance committee, which was the transformation and partnerships slide, because there's a huge amount of activity there and progress that often gets subsumed into the more formal quality and safety elements of the IOR. And just to say that in the health inequalities section, we have a programme, really extensive programme that's really gaining momentum across the organisation. And the update in the developments part of that slide talks about this huge improvement in data and intelligence products that we're developing as an organisation, excuse me, to support this work. I just wanted to call that out, because actually without that, some of the health inequalities, health population work just won't happen. And there's been a huge improvement in that and huge effort. So just wanted to add that and say thank you for that.
Thanks, Julia. And I think coupled with the sort of ambition and aspiration from leaders like Adam that recognise that actually you need the data, but you also need the awareness and the sort of desire to adapt and personalise services to make sure they meet the needs of the diverse communities we serve. So I think it's a really important aspect. Melanie, please.
Yeah, I was actually looking at the workforce part of the dashboard and reflecting on the significant drop in turnover over the last few months. The commentary refers to maybe some change in the way that it's measured and the metric itself, plus I'm sure that one of the drivers will be the current sort of uncertainty and amount of change that's going on in the NHS, meaning that people are valuing job security more. But I wondered whether, I missed the last People Committee, Tim, I apologise, so I'm not sure whether there was some discussion there, but I just wondered on the commentary as to whether that turnover fall off is expected to hold steady now, or whether it's a blip for some other reason.
Thanks, Melanie. Dave?
I'm happy to have an initial attempt at answering this, and Dion, I can see, is going to come in. I mean, I guess if we look at the ONS data turnover in public sector organisations, we would expect to see where we have it as our threshold. I think what you're right is the context in the NHS where there's organisations have been asked to reduce workforce numbers, etc. That is across the board, and thus we're seeing a kind of a relative contraction of available opportunities for individuals. So I think we have to wait and see. I mean, it's great to have it, and our stability index, Dion might talk about this, which is our measure of people who are in the organisation for a sustained period of time, is very good. I think the work that we're doing in people committees, the retention piece for people who join in that 1 to 2 year bit, which is where we see significant churn, and that's mirrored across, certainly in nursing professions. There might be an opportunity to kind of consolidate some of the learning from this period to help with that traditional model, but let's wait and see, would be my view. What do you think, Dion?
Yeah, thank you, Dave. You know, I think it's a really relevant point, you know, the kind of fluctuation of activity at the moment. But again, as a trust, we're focusing very much on how we encourage and support staff to stay well within the organisation. So again, looking very much at development opportunities and supporting staff to focus in those areas, but also again, encouraging people to be able to move and transfer as needed and as required. So again, I think it's fluctuating times, but lots of energy focusing on building that stability as much as we can, and we are seeing good traction with that.
Okay, is that all right, Melanie? Thank you very much. I do think it is a trend, as Dave and others have highlighted, that I think we're seeing across the NHS currently because of the sort of opportunities being more limited and the amount of change going on in organisations. So yeah, but plenty of learning, I'm sure, to be had from that. As ever, I think it's a really rich report, and we welcome you know, the sort of clarity, Dave, that the report provides in terms of the sort of, you know, different sections and the clarity of assurance around different areas and areas of focus that colleagues are looking at. So we're just asked to note the report, and thank you. I think that it's really helpful and a good addition, obviously, with alongside the AAA. On our quality section, and we'll start with the AAA report from the Quality and Safety Committee in August. So over to you, Julia, please.
Thanks, Krishni. So just to say, there were no areas to alert this time from the committee. I'll take the paper as read. Just a couple of things to highlight. One in the advised section from our Quality, Safety and Assurance group. This group's actually becoming a really strong backbone of some assurance into the committee by the number and breadth of subgroups that feed into it. So it's a really important group for us. And I've put in the text this time that concern was raised that some staff weren't aware of the rationale for the number of posts being considered or impacted as part of our value programme. And that was really important to hear, because I think it was communication, and the staff felt they weren't aware, as I say, of the rationale behind it. And they also, more importantly, didn't feel they could raise the issue. We have a very, very strong culture of speaking up. We have a really good process, and we know, and we see examples, and we talk to staff when they feel able to speak up. So just wanted to say publicly that we took the time to look at that, because we were concerned to hear it, and that we gained assurance that actually 2 members of Linda's team, senior members, are actually looking at that in detail, because we want staff to speak up, especially through challenging times. And absolutely, we listen and then act. So just wanted to draw that out. From the Mental Health Legislation Committee report, just wanted to draw out, we've mentioned bank staff a couple of times this morning, and we were slightly concerned that some staff who were taking bank shifts weren't required to undertake full training in prevention and management of violence and aggression. And again, it's a training that we're very proud of, because staff really need to be equipped with dealing with incidents that happen on some of our mental health areas. And again, both Linda and Sachin took an action to look at that and come back to us, because staff felt that they weren't able to access the training. From the Assure section, we'd had some concerns raised about the impacts of the reforms to the national welfare system, particularly the benefits element to it. And so we took time to look at the impact for our service users, excuse me, particularly in our mental health services, and what we're doing to try and mitigate that. And we had a great presentation around the use of our peer support workers who are embedded in all our teams to help with, who also can help with that. And also we looked at our links with Accommodation Concern, who are a voluntary service, and they provide specialist debt and housing and benefits advice. And I was absolutely blown away by the impact, some of the advice that they were giving, and some of the financial improvements in people's lives just by being referred to Accommodation Concern. So we have a really strong partnership with them, and we looked at that in the round. Our quality framework for the organisation was approved. Just pull out the service visit paper. We're starting to now get some really mature reporting from trends from our service visits, and being able to take forward actions from that. We approved 11 policies, which I haven't listed for you. We have a raft of clinical support policies. If anybody needs any information, we can supply that. And just wanted to pull out in the Celebrating Outstanding, huge breadth from staff and services, examples of outstanding practice, not least the one that Angela mentioned earlier from the Baby Friendly Gold Award, but so many more. So if you haven't had a chance to read those, I do urge you to, because they really give a sample of how staff go over and above every day. I think that's it, Krishni, unless there's anything anybody wants to ask.
Thanks very much, Julia.
Oh, sorry. Just sorry, Dave, before you come in, just to say we have had a workshop, but it didn't make the papers in time. So just to say, we did have a workshop around restrictive practice and the Health Inequalities Programme, which I mentioned earlier, and we will be bringing that back through for the next board. Sorry, thanks.
No problem. Thank you, Julia. Dave.
Thanks, Krishna. Thanks, Julia. Just to support Julia's comment on service visits, we have had some themes similar to the violence and aggression, but equally some staff reporting racist, behaviours from visitors and from patients, and we feel that is partially driven by some of the local context, political context potentially for people. So we have communicated out our Stay Well messages to teams. The executive team sent out a note earlier this week to encourage people to continue to speak up and also reach out for support and to report these incidents where they find them. That's part of being an anti-racist organisation. So just to emphasise that triangulation between service visits and then action that we take as an organisation.
Thank you very much, Dave. And of course, I think we covered service visits, didn't we, at the Council of Governors, Julia, that you chaired back in August.
Yes, yeah.
And I think that was probably quite helpful as well, wasn't it, to illustrate how we're now embedding that process of sharing the learning from these visits. And also, in fact, I was remembering that we did talk about, I think Jen Hollings very helpfully came and described the way we are working with Accommodation Concern with the Council of Governors in a Council of Governors workshop. It blew us away then. And I think at that stage it wasn't fully it was still being kind of evaluated as well. So I did connect Jen actually with the Chief Executive of Rethink Mental Health, or the Mental Health Centre. I think she was already connected, but he was really interested in the work we're doing around that, and making sure that other trusts were doing a sort of similar access to advice, etc. But I think that was really impressive. I just wanted to pick up, Julia, and I don't know whether Linda might want to come in on this, but there was a reference to the multi-agency safeguarding hub model and funding for that, and I just wondered whether there had been any I suppose resolution to that, and because I was a little bit concerned that that's been such an important part of our safeguarding arrangements across the system. So I don't know if anyone can update us on that. Linda, is that something you'd like to comment on, or Julia?
I'll let Linda come in if that's okay, but it's certainly, the safeguarding is one of our BAF risks, and we're due to look at our BAF risks in detail over the next 2 committees. Safeguarding is one of them, so that will be something that features in that, but I'll let Linda come in if that's okay.
Yeah, Linda?
Thanks, Krishni. So with regards to the multi-agency safeguarding hub, that's to do with our children, young people. We continue to deliver the service. We've actually increased our practitioners who cover the MASH service so that it's run effectively and safely. We also continue to provide safeguarding support within NHFT. So just to assure the board that we are meeting our statutory requirements with regards to that, and wider across the system, we continue to provide the service. The issue with regards to funding is one that's been taken forward, and certainly we are working to that with our ICB colleagues around that. But whilst we work through that, we will continue to deliver the service. Alongside that, the system partners are looking at a new model of how we will deliver that going forward, because there's various things that are happening nationally, including some areas that have gone with an all-age multi-agency hub. So it could look different, but actually the service will continue to be provided. I'll let Paul come in with regards to the other funding elements, but we are working that through. Thank you.
And Krishni, as Linda said, we are working with ICB to ensure that we do that. I think there have been some historical funding arrangements that we just need to unpick, which of course takes a bit of time. But essentially, the ICB will, regardless of the cluster arrangements, retain the responsibility to ensure funding or contribution to the funding for MASH. It shouldn't be left to NHFT to fund to fund the operation of the hub across Northamptonshire. So we're working on that, but inevitably it's going to take a little bit of time to get to the bottom of.
Excellent. Thank you, Paul, and thank you, Linda, for that additional clarity. And did you want to just come back in on accommodation concern, just to add the comment I think you were going to?
Yes, sorry, my hand wouldn't go up, which is unusual to the last minute. So, yeah, just to say, we've been after we had the presentation and work on accommodation concern, we've also linked with LPT, with Tanya and Jean to think about what's in line with the voluntary sectors they use as well, and the services they use, and there's a lot of similarities, which is good, and just making sure the collaboratives have that shared understanding between them, which has been useful.
Great. Thank you very much, Anne. So I don't think you wanted us to approve anything today, Julia, so it's just the noting, I think, isn't it, today's report. So thank you very much. And yeah, I mean, it's lovely to see such a long list of celebrating outstanding, by the way. You know, I think it is worth noting that, and always good to see, particularly from the Quality and Safety Committee. So thank you very much. We move on then to the Patient Safety and Learning Assurance Report, which is paper J. Over to you, Linda, please.
Thank you, Krishni. I will take the paper as read just to provide further assurance to Trust Board. This paper was reviewed, discussed in the Patient Safety Group meeting, which we held last week. So really good discussion around our incidents management, as well as looking more wider, the deep dive into areas where there's variation, increase in incidents, with rationale and assurance provided on those. So our top 5 themes, those were discussed within that meeting. I do want to highlight to Trust Board that we are now at an improved position with regards to our investigation of incidents. So previously we had reported this risk quite high for us as an organization, but we've got good grip on that now with the allocation of incidents, and certainly the working with our care delivery pathways to ensure that these are reviewed immediately and that we start to collect statements to have those reports ready. What's also of note within this is that we've included later on in the report the work that we are doing to engage patients and families when there are incidents. So again, this was an area that the Patient Safety Group were interested in reporting right up into Quality and Safety Committee, because we recognize that it is difficult. Sometimes the family are not able to engage immediately, but we should continue that engagement work, and certainly we're seeing the benefits of that when we're engaging families. I previously reported the issue around our low no harm incidents that were not always consistently reviewed, but we're now doing that due to the change in the ways of working for the patient safety team. So these are being reviewed as business as usual, and anything that needs to be addressed is immediately picked up. So some incidents that could be categorized as a no harm, we then get to find that out later. So that's now being picked up in a more timely manner to ensure that we've done our duty of candor, we've followed through on all aspects of our reporting. We have no RIDDOR incidents to report for this particular period. I also wanted to just highlight that our teams are continuing to do a lot of work around learning, right down from the wards coming right up to board. So Julia did allude to some of the work and the reports that come through to Quality and Safety Committee, again looking at incidents that happen and the effectiveness of the learning across the organization. We've continued to work with our practitioners so that they're able to demonstrate any improvements that are required following incidents. And this again feeds into our wider work that we're doing with regards to continuous improvement across the organization. So we are developing that work. We will be able to share more of that and certainly go through that assurance at Quality and Safety Committee. So that's a work in progress to demonstrate the effectiveness of our learning where we have had incidents and we've needed to improve a particular aspect of care delivery, or a service model. So we will be able to report on that at a later time. I'm happy to take any comments or questions, Chair. Thank you.
Thank you, Linda. Any comments or questions for Linda on that report? Okay. Oh, Julia.
Just going to add in for people who may be watching that the assurance around the safety group is really important because they've scrutinised every element of this paper. And actually the other people that attend that, we have a couple of patient safety partners, part of the patient safety national framework, and they contribute and they scrutinise and they're part of our system. And we also have others, patient representatives, etc. So actually it's a really, really good baseline scrutiny group that feeds into this. So don't take the lack of questions from us as anything other than we've looked at all the data in great detail and we're assured by the work underpinning it all. So thanks.
Thank you, Julia. Just perhaps a comment really, and Linda, maybe just a little bit of an explanation. I think under the ill health section, obviously it highlights that of the 132 incidents reported in July and August, 65% were patient death. I think for members of the public that might appear a little bit, oh, you know, what does that actually mean? I just wonder if we can say, for benefit of anybody who's watching really, that maybe just, I know we have our Learning from Death paper routinely presented on a quarterly basis or you know, certainly frequently associated with this, and we had this at the last report, but it's possibly helpful to just highlight that there are sort of the expected deaths and unexpected deaths. So Linda, I just wondered if you could add a word around that, which might be helpful.
Yeah, thank you for that, Krishna. And I think I'll take that comment so that we can clarify it further in our other reports that come through. Obviously, when we look at the information, and as Julia said, we have the discussion then, so we then start to assume everyone will understand. So with regards to our deaths and us saying it's 65% of those is because we do live in an area where we've got an aging population. So a lot of those will be planned. They will be age related. We also run hospice services. So again, we will see deaths in those areas, notwithstanding that a lot of people's preferred place of death will be in their own home, in their community. So people are not dying, not all people are dying in an acute hospital, for example. So we then report that. So as you rightly say, Krishni, a lot of these will be expected deaths. There will be what is within our normal parameters for reporting these. But on our DATIC system for notifying those deaths, they have the subcategory for ill health so that all deaths are classed from there. And then when we do our learning from deaths, we then recategorize them as well.
Great, thank you very much. Just helpful context, I think, and additional explanation in case anybody was concerned to read that. Thank you very much, Linda. So we'll note the report and the assurance provided. I think there's been a lot of good work around, as Julia highlighted, obviously the focus of the patient safety group. You know, there's a lot of positive assurance around, I think, as Dave, in fact, alluded to at the beginning, most of our incidents are very much within the sort of normal parameters. So very helpful to see the additional detail. Thank you. So we move on to the final report in this section, which is the Workforce Safeguards Report, which is paper K. Linda, so back to you on that, please.
Thank you very much, Krishni. I will take this paper as read. Just to provide assurance to the board, we do discuss all the workforce-related issues around our safer staffing, and this is one of the assurance reports that we then present to evidence that we are looking at staffing and ensuring that all our clinical areas are safely staffed. I won't go through all the information line by line because some of this is covered within the IOR that we've discussed earlier, which Dave highlighted. Some of the information is also being discussed within the report that Julia presented earlier around the staffing issues that had been raised. I do want to highlight with regards to our fill rates that we upload month on month on the Unify system, which is the 15th of each month. The areas that we will spend more time focusing on are those that will be below 90% or those that appear above 120%. So we've reported on those areas that are below 90%, which means that there's a decreased bed occupancy in those areas. What's important to note around that is where we see some of that decrease, particularly in our inpatient areas for children, young people, that's reflective of increased community support. When we see our mental health crisis houses, again, looking at the decreased occupancy, that's increased support by the community mental health teams. So when you look at it without that immediate narrative, it may look like we are seeing a decrease in occupancy. What's happening to those patients? Actually, they're receiving the care in the community in their own homes. So that would account for the reduced occupancy. We do have reduced occupancy in some of our other areas, and that will be to manage the acuity of some of the patients that we have in those areas already. So again, we then increase the support for those patients in the community whilst we try and manage the acuity of some of the patients that we'll be having in those areas. I felt it was important to then highlight that area with regards to our occupancy. The other area I did want to mention was around our trust level vacancies. So we have reported on our vacancies for all the clinical professional groups and wanted to just mention that whilst it appears there will be the vacancies for nursing, AHP, there's quite a lot of ongoing work around some of covering those vacant roles. So for example, we are seeing more of the staff who are working as long line bank staff moving into substantive roles. Again, it's important to note that the vacancies we have are not all due to the value program. We've got workforce plans where we do need to skill mix to grow some of the other clinical professionals that we've committed to growing, for example, our advanced clinical practitioners. As those posts were never on our establishments, we need to skill mix some of our current vacancy to then create those roles as those practitioners are getting into their qualifying phases for those roles. So you will see that some of our advanced clinical practitioners will have been nursing, they will have been AHPs. So currently that post is a vacancy, but as they qualify, we create a new post for ACPs. We did that previously when we were creating the post, skill mixing for registered nurse associates, and we'll continue to do those skill mixes. So just to provide assurance that those vacancies are not vacant because of the value program. Additionally, we have committed, like other NHS trusts, to ensure that our newly qualified practitioners, nursing AHPs, do have jobs. So a lot of them will be qualifying now. We've already seen some of those posts have been recruited to. So whilst the recruitment is in train, it's still a vacant post. So we do have preceptees who will be joining us in the next few months, and certainly that will again change the vacancy position. I also then wanted to highlight that there will be changes in our reporting on staffing with regards to agency usage as we mobilize more for our secure services. HMP Loudon Grange, which we've gone live with, they do have agency workers who are covering some of those vacancies. There's ongoing recruitment, which has been really successful. Just speaking to the Director of Secure Services, mentioning that for the Band 5 nursing posts, that 95 applicants. So again, evidence that people do want to work for NHFT. And as we recruit, we'll make sure that that covers all other areas that we will be moving to. We will see that position change as we take on HMP Ramsey, because again, there's vacancies there and there are some agency workers who are currently working there, but that position will change in line with our agency reduction process. I felt that I should highlight those because those will be the key changes that will come up. The other information, Chair, I will take it as read and happy to take any comments or questions.
Thank you, Linda. Very comprehensive. Any comments or questions? Joe, please.
Thank you very much. Thanks, Linda. It's a sort of tangential question, so it may be you or it may be Anne for this one. But taking your comments about bed occupancy and the shift towards community-based treatment in certain parts of our user base, at what point do we then start to look at our estate strategy in terms of capacity? Because obviously there are other parts of the system that are really struggling, and I just wouldn't want it to be, something that we have vacant beds in wards which are consistently underutilised. Thank you.
I'll open it up. Linda, do you want to come back in on that? I don't know if anyone else wants to as well. So Linda first.
Yeah, so the first part is where we have reduced bed occupancy, Joe, our staffing model reflects that. So if we've got, say, 2 patients, 4 patients, where we'd have, say, up to 12 patients, the staffing model reflects that. So we certainly review that, and it's needs-led. What would then help us as an organization is, like any area, we collect that evidence on where people are receiving their care, so that as we start to review pathways, we look at the areas that we need to increase. And that includes the wider work that we are doing internally around our estate and how we utilize our estate. So as we start to see the change in trends, driven by the needs of the population, we are very responsive to that as an organization. We have also seen some of our staff in inpatient areas move into the community teams. So actually our own staff, that's been development, career development, progression for them, moving into those community teams. So as we support our patients receiving care closer to home in their communities, we are also developing our own people and retaining our workforce, whilst colleagues are looking at the estate side, and Paul can come in because we've got the estate strategy that we are working to. So as this is going on, Joe, I just want to reassure you that absolutely we do review that, and we're now starting to shape our models going forward in line with the changes for the population. Thank you.
Okay, thanks, Linda.
Thanks. Anne, did you want to come in on this particular point as well?
Yeah, I was just going to talk about, because there are obviously 2 very different areas that have been highlighted this particular month, and part of the first half being around our CAMS, our children and young people's beds, which I'm sure Sachin will come in and talk much more about, but with proposals that we will bring them together onto one site, that will also give us an opportunity to review and work with the collaborative, who oversee those beds, the CAMS Collaborative oversee them, to think about what's the best modelling. And I know Sachin and Paul have done loads of work around clinical pathways and how we adapt and amend. So that's kind of like on one side, and then the other side around the crisis beds. I think it's really interesting because that's fluctuated with time, and I think we are starting to see different trends of movement into the community, particularly as we drill down into what happens in a local neighbourhood. And we're quite alive to that in ensuring we've got enough that's place-based crisis support, but also what does crisis support look like now? And so there's just some discussions about how we utilise the beds to the best effect through that co-produced approach, and think about what those communities need. So constant discussion, but it's coming a bit to the fore in ideas from those co-production groups as we move towards winter.
And I guess, Anne, that as there is a greater shift towards prevention and early intervention, that crisis model will adapt and shift anyway.
That's what you would always hope, and we would move much more towards community. There will always be a need for crisis, and one of the big changes we've seen this year has been around being able to have planned admissions. We never thought we'd ever get to that availability for people who have particular times in their health journey and their sort of their yearly cycle of situations in family, say, when they know that a preventative admission would really support them to not go further into crisis. And that's become much more to the fore, and that's where we're sort of constantly looking at how we make those adaptations. So as things start to work, we can look at those, which is a great place to be in, because at the beginning that wasn't an opportunity. So good shifts.
Okay, thank you, that's helpful.
Thank you, Anne. I suppose I was just reflecting there that I think there's still a rather sad statistic that unfortunately a lot of people who die by suicide don't actually connect with services at all before that happens. So I imagine the place where, we're a long way off. Ideally what we want is to ensure that the access, people understand where they can go to access the services that they need when they're in crisis. And sadly, there's still a lot of people who don't access services, isn't there? So we're probably a long way off from kind of losing that.
Completely. Yeah, there's a definite balance.
Yeah. Sachin, I think you wanted to come in on that question, Sachin.
Thank you very much, Joanne. Please take my answer as a double act with Anne, and Anne has kind of talked mainly about the adult mental health services, so I'll confine my answer to CAMS. So I almost feel that, I need to preface it by saying, let me tell you about the incredible work that we are doing in CAMS. So we have reduced, we are the lead provider, and we have reduced and as such, our beds in NHFT are open across the provider collaborative, but we have reduced the bed utilization by more than 50%, 53% to be exact, and we have decreased the length of stay also. So because of that, we are creating a lot of savings because we flex our nurse utilization. We don't have more nurses than we need on the ward. But what we are finding is definitely the intensity of patients that we would be looking after is much higher. And that's very good because before we would have to send them out of county to PQ, etc. So now even those high level patients, we are able to bring them and keep them in our service because we have that extra capacity within our beds. So I think that is really good. And the length of bed stay, as I've already mentioned, is down, and that's leading. I'm sure Paul has referred to the amount of savings that we are making in that. I'll leave that up to Paul to say to you. And we are wanting to reinvest that in community services. So we are, we are an innovative provider collaborative, which is led by NHFT. And we are constantly presenting in national forum. We have people from everywhere, West Midlands, Southeast, people wanting to come and see our model, talk to our model. So yeah, we are doing it. But in terms of your kind of query about beds utilization and that, so we are flexing the workforce, and the other bit is filled up by taking patients of more of an intensity than we could manage if we had full beds and we were having to send them out for children's PQ and children's LSU. So we are managing them there. So that is what is doing that. And we have kind of plans moving forward to bring in day hospitals. We are in all the schools to the point of this suicide management. Krishni, we are in schools, but we want to have, I mean, this is our aim of developing what we call the golden thread. So, it's right at where the patient is, like in the school and in social clubs, etc., to the crisis cafe, to day hospital, to that, we are picking up the patient when they are beginning to have anxiety and beginning to support them so that they don't kind of become dependent and into our services. So we are reinvesting that. And just another statistic, which I'm sure would be interesting in terms, this workforce planning and retention and everything is such a big issue. In CAMS, the 2 CAMS units we have in NHFT, we have no agency spend at all for the last, I think now I'm going to add another month and say 19 months. I was talking to people and I'm saying 18, now 19 months. And the national average is 39% of the staff is agency in CAMS inpatient units. So when I go to national forum and national meetings and say this, people assume that I'm lying and they want to know the statistics and numbers, and they're not satisfied until we give them that. They can't believe their eyes. So yeah, that's, those are the additional advantages we get out of doing this service. Thank you.
That's great.
Thank you,
So
Sachin.
the service is continuing to evolve.
Yes,
from
absolutely.
that. Okay.
That's
great.
We
Thank
are
you,
in the
Sachin.
forefront of that. Yeah.
Yeah, thank you.
I'm
Thank
happy
you, Sachin.
happy to meet up. I mean, if you want to have a chat about the innovations we are planning, happy to meet up with you, Joe, outside this meeting for that.
Thank you, Sachin. Thank you.
So thank you, Sachin. I think colleagues who were at the last development session might have heard me mention CAMS tier 3.5. That was the sort of term that we used to describe the move from using beds to intensive support in the community. And I think I've used this often to illustrate this is acute to community in practice. Demonstrated in mental health. I think it's really important to make those links for people because this work has been really forward thinking. Paul has indicated that has confirmed that the estate strategy will always follow the form of the services. So obviously we'll need to, once we see those trends, I think Anne was sort of alluding to this, once we see the clear trends, Anne and Linda, clearly we'll need to make sure our estate strategy is taking account of that, or our estates plan is taking account of that. And CAMS bed usage has reduced from more than 80 to circa 30 following investment in community services. And the reduction in bed usage has saved millions over the last 3 years. I think it's important to say, I remember very clearly talking to Sachin some years ago now, where on a Friday we struggled sometimes where, beds were needed and people would be phoning all around trying to get beds, and we'd end up sending some of our young people out of county. And I think that was sometimes the situation because there was a shortage of those acute beds for young people requiring were tier 4 beds. So to be from there to move to this position, which is better for our for our young people we're serving and better, more efficient and more effective does seem to me a very good story to be repeating and continue to build on. So it's another one to be proud of, I think, for all of us. So thank you, Sachin, for illustrating that. I'll just bring Natasha in, and then Sachin, if you want to come back in, we can bring you in afterwards. Natasha?
Thanks, Krishna. And I just wanted to say, as someone new to the board, what a fantastic discussion and confidence I got from this paper in terms of the understanding of the workforce to demand mapping that's going on in the trust. It was really impressive to see. So I actually had a question about staff sickness, but before I do that, I also wanted to say, I think we need to keep in mind in terms of the occupancy discussion, it's really important that we understand that occupancy levels will need to be lower in services that have high volatility and high peaks. And I think the fact that you're now able to accommodate all of your young people who need to come in for acute admission is really important and actually to be commended. So I'm really delighted to see that transformation. I think it's really important that we don't see low occupancy as necessarily a bad thing for those types of services. Linda, just wanted to touch on the staff sickness piece, because there was a statistic in there that still 36%, I think, of staff are off for anxiety, stress and depression. And I just wondered if there was any triangulation that had been done in terms of, is there anything common for that population in terms of services where those people are working, or any work that's been done to look at that as a group?
Thanks for that,
yeah.
Natasha.
Linda, do you want to come in, and then Dion?
Yeah, I'll come in. So we do look at that information, Natasha, in different guises and forms. So with regards to staff being off, we do look at it from a well-being perspective, which is the area that Dion will come in on. We also look at it from a health and safety perspective. So Anne chairs that staff group, group around staff health and safety issues. We recognize that we are a mental health community trust. So some of our own staff will have conditions, and when they are off, we do need to log it as that. And actually, we don't stigmatize the staff by then saying, well, you're a member of staff, but you're also receiving treatment here. So actually, it could be one of the conditions that a member of staff has. We also recognize that there will be incidents that occur that do impact staff well-being, and our staff are supported because we do have a lot of services that support our own staff, including our psychological therapists who are there to support our staff. What's also of note with regards to the report of these incidents, we are certainly one of the trusts who report better in this particular area, and that's to do with the offer that we have in supporting our staff well-being, i.e. the various time that staff have to then reflect, to ventilate, and actually we do have a lot more that's offered insofar as the support from our staff networks, so we can intervene quite quickly before situations deteriorate with some of our staff. So I could talk through a lot of the things that we have in place with regards to that, but I do want to assure you that we do look at sickness from team level right up to care delivery pathway level and wider across the organization to link that with where we are seeing increase in sickness absence. Is that impacting on care delivery? Are there more incidents coming through? So we look at it from various guises and areas, but certainly our people team are the ones who hold the ring on that. So I'll let Dion come in. Thank you.
Thank you. Yeah, Linda's covered that well, really. I think I'd just add that we've been very intentional in structuring the people team to be able to mobilise and support colleagues with that kind of audit and check what's happening in particular areas, and again triangulating that across with staff survey, the feedback we're getting in local areas and the objectives we've got in those areas to address that. And importantly, we work really closely with our staff side, so there's a lot of, again, deep dive activity happening, looking into reported kind of levels of stress and the feedback we're receiving. So we're bringing in a number of stakeholders to understand what's happening in local areas, and then working with teams and ops colleagues to ensure that we're putting the right interventions in place. So a clear focus for us and a big piece of work.
Thank you, Dion. And did you want to come in as well?
Yeah, I was just going to say some of that staff side work is also trying to get us into more of a preventative space. So we're doing some work with them and Dion's teams around how do you get a good indication of stress levels in a particular team, and how do we do that together and understand the piece so that people can talk, come forward, get different wellbeing supports to try and get ahead of that curve. And that's been a piece of work that we've been doing jointly with staff side to really understand that and analyse it further, and getting some sort of psychological expertise in the room to think about how we do that. So it's been some really good work that we've done with the people team.
Great, thank you, Anne. Natasha, does that help?
Yeah, thank you so much. It's been really comprehensive response. Thank you.
Great, thank you. Sachin, final comment from you. Sachin, I think you're still on mute. Can't hear you.
Sorry, sorry, Krishni. Sorry, I was on a roll of praising my CAMS team, and I just beg your indulgence for another minute to say, you know, in terms of the attitude of the staff is so much, like, it's just amazing. I think I have an amazing staff. Like, you know, there was a patient, I just want to tell you a short story. This weekend, a patient was admitted. He was assessed by the community team as needing a PQ. PQ didn't have a bed. We said, okay, we will hold him until a PQ bed became available. We managed him over the weekend, and on Monday, we managed him. The PQ bed would have been, the PQ said they'll see him on Wednesday. By Monday evening, my staff would kind of called me up and said, you know, Sachin, why do you want to send this child away? You know, although he had been assessed as PQ, we can manage him here. We are managing here. Why do you want to send him? We'll manage him. We'll keep him. And, you know, that's the attitude of staff we have. So it's really hard.
Thank you, Sachin. Thank you. And I think we've had some really moving stories about the support we've provided to young people and through some of our board discussions in the past. So we know that there's a lot of support and thought and compassion in those services. So thank you for highlighting that, Sachin. Okay, well, we move on to, I mean, we've been talking about people a lot already, but we do move on to the people agenda. I think the Workforce Safeguards report always crosses that boundary between people and workforce. And indeed, that report does actually go to our people committee as well, doesn't it, Tim? So over to you for the AAA from the August meeting, Tim.
Yeah, I feel a bit deja vu, actually. A lot of the topics have been covered already as we go into the AAA report, but just for completeness, I'll take the report as read. There were no items at the last People Committee for alert. There was one advice, which Linda's already discussed, which was the monitoring workforce safeguards, which was around the vacancies that we are carrying in those areas. Every other report came within Assure. There are a couple of things that I would like to highlight. The workforce dashboard really pointed to the progress that's being made. And already people have touched on either turnover, but we also got improvement in vacancy rates and sickness as well. So all the trajectory across the board is generally in the right direction in those areas, which shows good progress that's been going on, not just within the people team, but management and leadership across the whole of the trust. The agency spend report was very good insofar as it reported on M3. There was very much an expectation that M4 might, there was a timing issue there, which Paul will probably point to. But by the time we get to M4, we expect to be closer to M2. But there's been some really good work on agency spend. And now there is more of a focus on the bank spend. So that now will fall into the remit as well to be discussed. The only other item I was going to bring up was that the committee approved the new updated terms of reference, and particularly the inclusion of the Chief Finance Officer, and to align it to the new Thrive strategy as well. That was everything from the committee. The following week, we had the first people workshop as well, which is not covered in the reporting, but just to give you all an update. And there was very, very good papers, 2 particularly good presentations. The first one by, Dion, Save Your Blushes, on the people priorities, particularly around proposed governance and assurance and the work that's going on there. And the second one was a presentation by Dion and Mike Asbury on NHF Thrive Together and our culture. Great discussion on that, and particularly what we will see in future people committees as well. So so the people committee is in pretty good shape at present.
Thank you very much, Tim. Any questions for Tim or comments that anyone wants to make about that report? We've probably had a fairly good discussion about the people elements. Angela?
Yeah, no, really helpful, Tim. And I think the workshop, as you said, was obviously timely and useful. And again, thank you to everybody's contributed that, Dion particularly. But I was really encouraged to hear that you're going to be focusing more on the bank elements, because I think that's something that, as we've heard through some of the discussions already, we really need to understand our bank usage for a number of reasons. And we know that our regulatory discussions will focus on this with us. So I think it's timely that you're saying that we'll be more focused on that and understanding. And Dave's touched on it as well in terms of the value programme. So I was encouraged by that. Thank you.
Yeah, thanks, Angela. It's certainly, I think, got a lot of regional focus, because I think the agency spend has been obviously improving, and I know the region, certainly at the last regional people board, was still highlighting the importance of focusing on bank. Notwithstanding the point that Dave made that, you know, we do want a flexible workforce, so there's a balance, isn't there? But importantly, it can't be that, you know, we're just sort of I guess overusing bank as well in terms of reliance on that, particularly in terms of the value programme. So thank you for the report. We do need, I think, as the board, to approve the people committee terms of reference changes. They are clearly highlighted, and as Tim has mentioned, they are predominantly around just sort of changes to membership and alignment with the Thrive strategy, which all seems to make absolute sense. So is everyone content just to approve that for the record? And we'll note that in the minutes. So thank you very much. We have item for information is just our declaration of interest register, which is available obviously for colleagues to note. And just a reminder that we need to make sure we're keeping that up to date. I've got no other business that I particularly wanted to mention. We are somewhat ahead of time, but we can be generous. It's always difficult to judge. I think when we were doing the agenda planning, we thought we'd allow a bit more time for the pathway story, but we did actually acknowledge this was a slightly lighter agenda, and sometimes the national, there's less of a national ask. So but I think we gave a good airing to all the papers that needed it. So any points of feedback regarding items and timings, and was there anything else that colleagues would have liked to have seen on the agenda today? And were there any other risks or communication issues that anyone wanted to pick up? So a brief opportunity for any reflections regarding the meeting before we close. No, everyone quite content, Julia?
Yeah, no, just to say thank you for your last public board chairing. Papers have been great. I think there's been some really, really good conversations. I think we've all been alert to the risks throughout the different papers, and I think we've linked up and joined up an awful lot of information that comes through, and particularly big thank you to Adam and the story. It was phenomenal, and I was there at the first one too, and the movement on and the improvement is incredible. But yeah, I think good set of papers, discussion on the right things, and really good session. Thank you very much.
Great, thank you. And I'm very pleased that in my last public meeting we have managed to give you half an hour back almost. So that's pretty good. The date of the next meeting is Thursday, 27th of November at 9:30, and Faisal will be in the chair. I sort of wish him all the best with that. I know everyone will support him absolutely.